So in terms of learning objectives, I've been given about 10 minutes to speak on a topic I have read textbooks and attended many workshops on. So very briefly, I'm going to share some of the most common motivational interviewing and goal setting strategies that I use in my practice at the Chronic Pain Center. And if I've piqued your interest in the topic, I have a list of resources at the end of the presentation to help you get started in diving deeper. Next. So I'm starting off by just sharing a little bit about the spirit of motivational interviewing for goal setting, which is captured by the acronym RULE. So the spirit of MI, or motivational interviewing, is really about helping the patient develop and understand and explore their own motivations for change. Research shows that trying to persuade people to make a change based on your motivations is rarely effective, and that when not just patients, when all of us are actually interested in making a change, when we're convinced that the benefits of making a change outweigh the costs of making a change, when we are involved in making the plan to change, when we feel ready to make a change, when we're confident to do it, when we feel that we have the support to do it, that we're empowered to make the change, that's when we're going to be the most successful. So as healthcare practitioners, we sometimes have this writing reflex where we want to say, I'm the one with the training, I'll tell you what to do, or we don't spend enough time listening to the patient's motivations, or we're just motivated to cure the person and get them out of the office so we can see the next person. That's not an effective way to actually have that person come to your office less, but because they've achieved their goals. Motivational interviewing really emphasizes spending equal amounts of time listening as talking. That's really powerful for patients. And in that time, you're exploring their perspectives, again, their motivations for change, their ideas, and so on. So the RULE acronym is just sort of a reminder of these kind of general principles for motivational interviewing. Next. And so within that kind of general context, there are so many techniques within the MI approach that you can use to help patients set and achieve goals. I do not have time to go through them all. Again, resources at the end if you want to dive deeper. But these particular strategies on this slide are the ones that I'm going to go into in a little bit of detail today. Okay, next. So to start off with goal setting, what I found when I started at the Chronic Pain Center was I would ask patients in my group, what is your goal for this self-management group or this sleep group? Or what is your goal for working one-on-one with a psychologist? And 90% of people would say something like, well, I want better pain management, or I just want to feel better. And so I'd go around in my group and say, and what's your goal? And what's your goal? And everyone would say, yeah, me too. I also just want to feel better. Yeah, I also want to have less pain. And it wasn't really effective for me to keep hearing that again and again. And maybe some of you have that experience too, where your patient says, my goal is better pain management. And that's kind of hard to work with because you want to know more about the person. So a strategy that I use a lot to turn a vague goal, like I want to feel better, which is what I hear a lot, into something more concrete, is asking what's called the miracle question. So something like, suppose tonight while you were sleeping, a miracle occurred. And when you woke up, you felt better, or you felt like yourself again, or you had better pain management, or you felt happy, whatever their kind of vague goal is. So you woke up tomorrow and you felt better. What would life look like? Or what would you be doing And this, like Drake talked about in the presentation 2 weeks, helps make the goal functional and behavioral. And that's where we can start to intervene a little more concretely. So the patient says, if I felt better, I would be exercising. I would be seeing my friends more. I'd be playing with my kids. I'd have more intimacy in my relationship. I'd be in a better mood. And now that gives us something more to work with. And if you say, okay, out of all of those things, what is the most valuable thing for you? Or what would you most be excited about? And they said something like seeing my friends. That would just be so amazing. Great. Well, we can start there. Just that question can give us a really targeted goal to work on. So now we went from I want to feel better to I want to see my friends more, as an example. Next. So that's better, but it's not perfect. So I'm sure most of you have heard of the SMART goals strategy for making a goal more workable. Hopefully, most of you know SMART as a goal setting technique, but one thing that I learned from my psychology colleagues at the Chronic Pain Center was adding another S to the acronym, making it SMARTS instead of just SMART. And this I found to be so invaluable. So adding the second S is sabotage proof. This is a step that I've seen skipped in a lot of textbooks and other knowledge resources. So in this step, you invite the patient to consider the barriers or excuses that we all come up with when we set a goal. So what might actually prevent the person from executing the plan? So I kind of usually volunteer when I'm talking with patients that I have never successfully executed a New Year's resolution. And it is because I fail to consider all of the excuses that I will come up with. I can be so motivated to exercise more or eat healthy or whatever, and I can come up with a specific measurable goal, but invariably I'm too tired, or I'm not in the mood, or I'm too busy, and I can come up with 1,000,001 reasons not to execute the goal. And so to think of these things ahead of time while you're, still motivated to actually come up with this goal can be really, really important. So if the goal is, I want to see my friends more, making it SMARTs might be something like, I will text 2 friends every week to plan a shared activity or just to chat, because that's specific, that's measurable, it's action-oriented, it's realistic for this person, it's time-oriented. But then the second piece is that it's now sabotage-proof. If I get anxious that no one will want to see me, I'll remind myself, you can't score a goal if you don't take a shot, because maybe this person is especially anxious that, if I text this person and they don't want to see me, I may as well just not text them at all. Next. And as you are kind of helping people come up with goals, you're also in the background assessing stages of change. I don't know on your screen if you can see all of the text on this diagram, but research shows that when people are intending to make a behavioral change, there's a very predictable process that they go through. So while, or even before you're helping somebody set a goal, you're always thinking about their readiness to actually make the change and where they are in this process. So briefly, pre-contemplation is a stage where the patient is expecting a cure. They're not even ready to think about making a behavioral change themselves. They're expecting you to cure them. Contemplation is when patients are open to thinking, oh yeah, maybe there's something I could do differently, but I'm not sure, I'm not committed to actually doing it. Preparation stage is when the person's ready to make the change and they're preparing to do so. Action stage is actually making the change. Maintenance is when the new behavior is now routine. And a lapse or a relapse is when the person falls back into their old behavior and maybe needs some additional support to go back to the new way of doing things. Or maybe, they say, I've done it, didn't work for me, I'm pre-contemplative about it. So in the MI framework, there are lots of strategies you can use depending on which stage your patient is in. I don't have time to go through all of that today, but again, if I've piqued your interest, there are resources at the end that can help you dive deeper into what to do based on what stage your patient is in. So what I'm going to do just in the last few minutes here is to share a couple of the most common strategies I use for patients who are in contemplation or preparation stage. Slide. So the decision-making matrix is one that I love. I use it a lot, and it is so helpful both on my end and for the patient in exploring their motivations for change. So often we encourage patients, and again, we do this ourselves, to think about all the negative parts of staying the same. So let's say, you're trying to help somebody quit smoking. What are all the negative parts about smoking? And what are all the good, positive parts about quitting smoking? This is actually not that helpful when it comes to behavioral change because it leaves out two really important concepts. So we all know, and our patients often know, there are bad parts of smoking and there are good parts to quitting, but then that's actually invalidating for what is actually keeping them going with smoking, or what's actually maintaining the current behavior and what's making it so hard to change. So to add to this pros and cons kind of table, we add what are the benefits of staying the same, the way things are, and what makes it so hard to change. So in this particular context, where the goal might be, I want to see my friends more, what are the benefits of just staying the same? What keeps you from seeing your friends more? Well, it's easier just to stay home. That can be really good information for you to know. But what are the benefits of changing and actually seeing your friends more? Well, I'll have more positive experiences. What are the downsides of staying the same and staying isolated? Well, yeah, I feel isolated and I don't like that. And what are the downsides of changing? What makes it difficult for you to make the change? Well, it takes so much effort to get ready and I get anxious, no one will see me, and the list goes on and on and on. So what this does is it really validates the person's experience. It's so important to recognize the good bits of the current behavior and the hard parts of making the change. And by doing this, a patient might realize that the goal that they've come up with, actually making that change, is going to be really hard. And well, it's not going to have that many benefits. So maybe that's not the best goal for me. Yes, I can acknowledge there are benefits to changing and consequences of staying the same, but actually the consequences of changing, the barriers to making this change, are going to be so hard, and I'm not ready to do it. That's so good to know now before the patient feels like they failed their goal and you get frustrated as a practitioner. Why didn't this pan out the way I thought? Slide. Another strategy that I use a lot is really exploring that dilemma. What makes it so hard to change? Sometimes patients want to make a change, but they're really hesitant about getting started. So here are some questions that you can ask to help them explore their motivations for change. Now I want to see, okay, I saw Dr. Montgomery's comment of, spoiler alert, this is all really useful information, but I was waiting for the but, and I was like, oh no, what's the but here? Okay, thanks for that conversation, for that point, Lori. Yeah, so these are questions that I ask all the time in my practice to help explore patients' motivations for change. I'm not going to go through them one by one. I don't have time for that. You can read them on the screen. Okay, next. And so the final or penultimate strategy that I use in most frequently in the context of MI is assessing confidence and readiness. So you've come up with a SMARTS goal, the patient, you've assessed that the patient's in the preparation phase. They're starting to put together all of the things and tools that they'll need to get going on this behavior change. And my final question, or questions, I guess, for patients, is about their confidence on going ahead and going from preparation stage to action stage. And if they're ready, if they feel like they've put all the pieces together to make the jump from preparation to action. So asking scaling questions. On a scale from 1 to 10, how confident are you that you can achieve this goal? And on a scale from 1 to 10, how ready are you to begin working on this goal? If either response to those questions is less than 7, we need to go back. Somebody can feel really excited about their goal and I'm ready to text my 2 friends, but my anxiety is still a little bit too much. I'm not exactly confident. I'm not ready, or for whatever reason, or I need some more support. So asking these final questions after you've come up with a nice concrete goal can be, again, just other tools in your toolbox to help you make sure that the patient can execute the goal. Okay, next slide, please. And then finally, my final note is that even if you've done all of these strategies and all the other strategies in the resources I've provided, another very valid outcome is that the patient still doesn't know if they want to actually move forward on a particular goal or any goal, or they just decide, you know what, I want to stay the same. I don't want to make any behavioral changes at all. Try to kind of minimize the frustration around that. That's an equally valid outcome as the patient wanting to make a change. So respect that. Ultimately, it's their choice to make whether or not they want to make the change, or if they're still ambivalent about it. At your next appointment, you can either explore the ambivalence or explore a new goal, start from scratch. And that's completely fine too. That's really respecting the patient's decision. Okay, and so I hopefully didn't go too much over time, but I've given you some resources that I think are specifically helpful to a family practice setting. I think that's where most of the folks in this group are coming from. So these are some options that will give you, that might quench your thirst for more if I've piqued your interest. So thank you very much and happy to take questions.
Thank you, Dr. Mallya. We do have maybe 1 minute for one question and then we'll have to move on, unfortunately. If anyone has anything pressing. If not, you can put your question in the chat and we can forward them to Dr. Mallya afterwards.
There's just a comment in the chat just saying people like that extra S. Perhaps all of us have that self-sabotage problem in life. And so that was one comment. And our other comment from Lori is stay tuned for the next echo when we talk about the inherited patient on opioids. So
yeah, super good information. Thank you so much. And again, it's very relevant, not just to our patients' lives, but our own as well. So
absolutely. Thank you.